Okay, I'm gonna try again.
It's just not super fun for the people.
Oh, we can see it.
Okay, let's just holler if it goes away again.
Okay, thank you.
Yeah, sorry. Um, okay, so the bulk of what we're going to be focusing on today are the things that activate our adrenoreceptors. So things originate here at a preganglionic neuron, at which point acetylcholine is released and can then go either impact receptors in the adrenal gland that then release things like epinephrine and norepinephrine, or it can then go on to a further sympathetic neuron, at which point you can see more acetylcholine release or norepinephrine release. Ooh, I feel like this table, for the purposes of when I became an anesthesiologist, I had to know the nitty-gritty of all of these receptor subtypes. For the purposes of this talk, the big takeaway I want you to think is alpha, think vessels, vasculature, vasoconstriction, beta, think more heart heavy. And we'll get into that in a bit more detail. But in looking at how these different uh, endogenous things work, norepinephrine and epinephrine have pretty equivalent activity at the alpha receptor. And then when you get to beta effects, epinephrine has quite a bit more activity than norepinephrine. Um, and that begins to make more sense why epinephrine is the drug that we will use in the face of an arrest situation and not norepinephrine, anaphylaxis, etc. Epinephrine would be your drug of choice. Okay, so alpha 1 receptors are primarily vasoconstriction. Um, Anybody know what kind of drug acepromazine is?
Yeah.
Yes. So do you know what it does to that? So it also binds the alpha 1 receptor. Do you think it's an agonist or antagonist? Good. Yeah. So I like to think about how we can compare different drugs that we give to kind of understand why they're doing what they're doing. So something that is an alpha 1 agonist is going to cause vasoconstriction. Acepromazine is an alpha 1 antagonist, and that's why you see vasodilation when you give acepromazine. Alpha 2, these drugs, anybody doing anesthesia, sedation here is probably very, very attuned to what you will see when you give an alpha 2 agonist. You get venous vasoconstriction. So all of your alpha 2 agonists, dexmedetomidine, probably the one we use most frequently, you'll see venous vasoconstriction. Um, these are really cool because they're located all throughout the body. And the nice thing about giving something that causes this vasoconstriction is that you can mobilize blood volume from some of the less crucial areas of the body to bring back to the things that are a bit more important to maintain perfusion. Um, there are alpha receptors located within the myocardium, and they're actually responsible for about 0.25% of the positive inotropy that we see. And then in terms of the beta receptors, there's three different subtypes. They all coexist on the myocardium and vascular tissues. The ones that are on the vascular tissues cause more vasodilation, again, to maintain blood flow to vital organs. And then you can also see some visceral and bronchial smooth muscle relaxation with beta receptor binding. Beta 1, again, thinking about norepinephrine and epinephrine, pretty equivalent effects of these two agents. This is the first to be impacted by acute increases in sympathetic tone. It's a positive inotrope and chronotrope. So what that means is that it will help improve contractile strength and increase heart rate. The nice thing about this is that you want to continue perfusing your myocardium well, so you will get some coronary vessel vasodilation, which helps maintain blood flow to the heart in these states. And then beta 2 receptors, epinephrine, much stronger activation than norepinephrine. This is why we're reaching for or epinephrine, excuse me, in the face of, again, arrest, anaphylaxis, because you'll get more of those beta 2 effects, bronchial, vascular, you'll get some relaxation overall that is a bit more beneficial in those high crisis moments. So in thinking about beta receptor effects within the heart, when we start something that we're looking for the beta receptor effect, we're trying to increase cardiac output, increase heart rate, and increase contractile strength. And then within the vasculature, you'll see that vasodilation. And if you've given something that has caused vasoconstriction, it will help offset that a bit. All right. Does that quick background make sense before we talk about drugs? Okay. All right, this chart really runs through the components feeding into oxygen delivery. So we have the two main things that make that up are your arterial oxygen content and then cardiac output. The main thing that we're obviously thinking a lot about arterial oxygen content. In anemic patients, thankfully, most of our patients are not anemic, but that side of the table is usually stable in, I'd say, about 80% of the patients here. Cardiac output is the big thing I'm thinking about and how I can impact that in my hypotensive patients. So the things that go into cardiac output are stroke volume and heart rate. Stroke volume is then made up of things you're thinking about: contractility, preload, and afterload. So all of those things we can try to help tweak under anesthesia, either with volume or pharmacologic intervention. All right, so norepinephrine is an endogenous neurotransmitter. Morning. Has more alpha effect than beta effects. And then within the beta breakdown, it has more beta 1 effects than beta 2. Pretty large dosage range. I did put that you can consider additional intervention when you're starting to get to higher rates of norepinephrine. I think that's a rule of thumb with any of these pressors. If you're getting to the high end of the dose range, you need to think about a second intervention. What you see with norepinephrine is intense vasoconstriction. So this increases sorry, I'm just going to move my little, oh, I didn't even realize I could probably get rid of it. Oh man. There we go. That increases your systemic vascular resistance, and then you increase contractility because of those beta 1 effects, which increases your stroke volume. A lot of what we know about norepinephrine use, we glean from the human side, where it's a much more frequently used intervention in the face of hypotension. And the main place that it kind of gets its badge of honor is in the face of sepsis. The Surviving Sepsis campaign, the most recent article came out in 2021. Norepinephrine remains the vasopressor of choice to maintain mean arterial pressure above 65 in these patients. Their second intervention, if needed, is vasopressin. And then the other thing that I will try to write home about in all of this: before starting a pressor, you always want to make volume status is appropriate before you start any pressor. This just quickly is directly from those Surviving Sepsis guidelines, reiterating the driving home point that they always consider norepinephrine as first line, and then how to add on from there. A few papers just looking at norepinephrine versus some other pressors. So this one looked at norepinephrine versus dopamine. Again, this is a human paper, but norepinephrine was quite a bit more predictable and efficient at augmenting cerebral perfusion pressure in patients with traumatic brain injury. Dopamine changes were not as consistent and were quite variable. Um, One veterinary paper that came out in 2015 looked at a review of most of the common vasopressor drugs used in septic shock. And again, from the human literature, norepi was the first line. Veterinary literature was lacking, but from this paper, it was still the number one choice. And then there was a survey study amongst ECC diplomats that came out in 2022 that again was just a survey to assess what they used in these septic shocky states and their parameters for when they would institute a pressor. And from this study, norepinephrine was still number one. So I think the main point in all of this is that norepinephrine in the face of septic shock or any other shock state with significant vasodilation, once you have volume resuscitated, norepinephrine is still the first line pressor that you should be reaching for. And I argue too, that I would call it an I know pressor because it does have some beta effects as well. But strongest as a vasoconstrictor. All right, so key indications, sepsis, anaphylactic reaction. Maybe if this is what you have, again, I would still pick epinephrine over norepinephrine as first line in the face of anaphylaxis. Vasodilatory shock, so, anything that has had massive blood loss. Patient not responding to the initial pressor, unless it's in the face of sepsis, again, first line. And then any situation in which systemic vascular resistance is reduced. And we can see this on occasion. I think we see it more commonly in cats. You can get sympathetic blockade from your epidurals, in which case nothing seems to work in the face of their hypotension, and they really need something that's going to cause a good amount of vasoconstriction. I put maybe cats. I don't hold as firmly to that here, but I do, as a rule, think that cats respond better to norepinephrine than most of the other things that we do. So that you can take that for what it's worth, but I probably should use it more in cats because I do think it's more effective more quickly. All right, dopamine. This is the one that I tend to reach for the most, and I think a lot of that just has to do with your training and what you use the most. But dopamine is an endogenous catecholamine and neurotransmitter, and it's a precursor to norepinephrine, which helps explain why it has many different effects. I remember when I was studying for my board exam, I listened to a podcast about different pressors, and the anesthesiologist giving the podcast called this a dirty pressor, which is kind of funny, but also makes a lot of sense because it binds to so many different receptors throughout the body and has effects that range because of this. So dopamine has different effects depending on the dose that you are administering. The main thing we're trying to do in hypotensive anesthetic patients is increase cardiac output and mean arterial pressure. So I'm really playing into that moderate dose range of 5 to 10 micrograms per kg per minute, trying to hone in on the beta 1 contractility effects to improve blood pressure. When you get to the higher dosage range, you can see some vasoconstriction as well. But dopamine, like dobutamine, when you get to some of those higher doses, because it is heavily binding the beta 1 receptor within the heart, I tend to see more arrhythmias the higher I go. And then I'm giving something that's then vasoconstricting on top of that, which can make the heart even more unhappy. So just something to think about. Very rarely we're running at that low dose range, except when we are trying to titrate something off of dopamine at the end of anesthesia. But once I get below 5, and their pressure is holding, I think that their body's doing a pretty good job. Okay. In terms of those renal effects, historically, dopamine had been used quite a bit in the face of kidney failure. Um, it does bind those dopamine receptors, but low doses were not effective in promoting renal blood flow and urinary output in cats. And dopamine has pretty much completely fallen out of favor as a intervention in the face of kidney failure, at least at these low doses. Um, this study looked at the response of hypotensive dogs to dopamine versus dobutamine when they were very deeply anesthetized. Dopamine did cause significant dose-dependent responses to achieve your target blood pressure, and it did improve urine output in this study. When they combined dopamine and dobutamine, there was no increased benefit over dopamine alone. I'm not really sure why you would ever combine those, but for the purposes of this study, they did, and it was of no benefit. Again, looking at dopamine versus dobutamine, this one was in the face of rapid blood loss. I believe, if I remember correctly, they did steady state, no blood loss. Then they did 10 mils per kg, rapid volume blood loss, 25 mils per kg, rapid volume blood loss. So a significant amount of blood volume. And then, while simultaneously replacing with crystalloid, they compared dopamine and dobutamine. And in this situation, dopamine was suitable for at least temporarily helping to manage blood pressure decreases in the face of blood loss, and it was more effective than dobutamine. So key indications, and probably why I reach for this more frequently in the face of pretty, I would call standard anesthetic hypotension, is that this is just standard hypotension in the face of an animal that's received adequate volume resuscitation. Hypotension temporarily in the face of hemorrhage. Yes, you can absolutely start it, but the main thing you have to think about in those situations is trying to replace that volume as quickly and adequately as you can. Improved renal perfusion. Potentially there's this direct effect, but really no good evidence for improvement in true renal function. Initial agent and non-septic shock. Yes, that is fine. Not recommended as a pressor in sepsis. All right, dobutamine. This one is beta. For all intents and purposes, I think dobutamine, beta primarily. Beta 1 and beta 2, some alpha 1 effects. And I don't know if you've ever heard the BU beta 2. That's kind of how I always remember that dobutamine has this additional beta 2 effect to its beta 1 effect. But the main thing that we're trying to accomplish by starting dobutamine is, again, increasing contractility, increasing that strength of the heart with each contraction to help increase cardiac output and stroke volume. You'll see minimal increases in blood pressure, oddly enough, but you will improve cardiac output. It does cause some decrease in systemic vascular resistance because of that beta 2 effect. Dosage range listed here, again, when you get to those higher doses, because of receptor binding, you can see arrhythmias. I tend to see arrhythmias more frequently with this drug in larger dogs at higher doses. Don't tend to see arrhythmias quite as much in cats at higher doses. Looking at, again, I think this was the same study, the dobutamine versus dopamine. Dobutamine did affect cardiac output and heart rate, but it did not increase blood pressure. in this study compared to dopamine. Um, Indications, cardiac insufficiency due to sepsis. So dobutamine is usually what I am grabbing as my second agent in the face of sepsis. After norepinephrine, I'm getting to kind of the high end of the dosage range. DCM is the poster child for dobutamine, which makes sense. So these dogs have big floppy hearts, very poor contractility. So we want a drug that whatever contractile strength remains in that big dilated heart. We want something that's going to help improve that to the best of our ability. So the DCM dog, if I have one with a history of that, and it's not septic, it's just standard anesthetic hypotension, this would be the drug that I would reach for. In that case, severe mitral valve disease, I think you could use dobutamine or dopamine combined with another vasopressor. And if any of you are doing horse anesthesia at some point, this would be the drug that almost every horse will receive under anesthesia. And you just drip it in. All right, phenylephrine. This is one that we're not using too commonly, so I'll just zip through it pretty quickly. And the reason that we might use it, so this is a synthetic drug. It has direct effects on the alpha-1 receptor, really no beta receptor activity. It mimics what norepinephrine does. It is longer lasting. It causes minimal CNS stimulation. The dosage range is here. This study looked at different pressors in healthy anesthetized cats. Phenylephrine was very good at increasing mean arterial pressure and systemic vascular resistance, having minimal to no impact on heart rate. So, I think I've used phenylephrine in 2 cats in my 10 plus years as an anesthesiologist now, and they've been cats with terrible, terrible HCM that really could not have any significant increase in heart rate would have been really detrimental to these cats. So these are very few and far between cats with very advanced heart disease that need a slower heart rate. This is a drug that you can give to help increase blood pressure without really having any effect on heart rate. This is one also that we use in horses as an adjunct agent too. But again, no horses coming in here anytime soon, I don't think. So something you could add on, this is one that you would be really cautious about giving in septic patients, but good thing to think about if you have a patient that an increase in heart rate could be really detrimental. If you ever use phenylephrine, I will say that subjectively, your patient looks horrendous. They go ghost white because it is such a potent vasoconstrictor. Don't be alarmed, but I mean, it'd be a little alarmed, but it's just something so you're not shocked when you see it. Okay, ephedrine, really cool drug, really hard to get, so not commonly used anymore. But this is the one agent within this talk that you can give as a single bolus, which is really cool. Much more user-friendly, I would say. Used it quite a bit during my residency. Now it's just become harder and harder to find, so less commonly used. It is, again, another synthetic drug, has direct actions on your alpha and beta receptors. It's, again, easy to use. You give it as a bolus. The nice thing is that it tends to work really effectively one time as a bolus for about 20 minutes, 15 to 20 minutes, and then you start to see your blood pressure drop again. You can attempt giving additional doses, but the pharmacologic term they use is called tachyphylaxis, in that it's a drug that usually does not have the same effect twice. And if you want to have a similar effect again, you have to keep giving higher and higher doses. So this was a nice one that, you're getting to the last 30 minutes of a procedure, you could just give it as a bolus, and that would usually carry you through. Yeah. So in this study comparing ephedrine and dopamine in routine anesthesia, they were both effective at improving cardiac output and oxygen delivery. Again, like was just said, the pressure elevating effect of ephedrine was pretty transient, and that strategy of having to redose, likely with higher doses, is more likely with this drug. Vasopressin, I think this is last but not least, is arginine vasopressin, is the long form endogenous name of this vasopressor, non-adrenergic in the face of severe hypotension and hypovolemia. It signals the release of vasopressin from the hypothalamus, and it increases blood pressure in septic shock or cardiac arrest by activating this AVPR1A receptor, or the vasopressin receptor. So with this, as a pharmacologic intervention, you see significant increases in mean arterial pressure. You can see really no significant impact to cardiac output, but it does increase perfusion to your coronary arteries and cerebral blood flow. So important things, brain and heart. Why we see this used pretty commonly as an add-on to norepinephrine and in the face of arrest, because of where blood flow changes are most impacted with vasopressin as an intervention. In looking at vasopressin, this is again human paper. So in humans with catecholamine-resistant septic and post-cardiotomy shock, vasopressin was really powerful in these patients that had other catecholamine-resistant septic shock. It did have adverse effects on GI perfusion, but the patients were dead, so we can work with that. Vasopressin therapy in dogs with dopamine-resistant hypotension and shock. This was the first vet paper that documented the use of vasopressin. Again, really small sample size, but it was very effective at increasing mean arterial pressure really quickly. Most of these patients got a pretty low dose, but higher rates were needed in 4 out of the 5 dogs. So key indications for vasopressin, again, shock states that are not responsive to fluid resuscitation, or in the face of an animal where almost every other pharmacologic intervention has failed, with or without epinephrine in these cardiac arrest states. And the one add-on to that is that most patients that have arrested, when you check a blood gas, they have pretty significant acidosis just by attribute of dying and how electrolytes are changing and shifting and cells are breaking down. So this is a drug that has been shown to work in the face of acidosis and hypoxia. It's just quite expensive, which is why we still use it pretty infrequently. Okay, so what to choose? In all of this, you want to ensure again that you have adequately resuscitated your patient with whatever volume resuscitation intervention that you need, be it crystalloids, blood, colloids, hypertonic saline. Synthetic colloids have sort of fallen out of favor, then they were just I have no idea what to do with colloids. I don't know that anybody does, but that's another talk for another day. Ensure adequate anesthetic depth. So are there things that you can do to try to scale back on the inhalant that you need, be it CRIs, different multimodal analgesia techniques, etc. And then decide on the case of hypotension. For most anesthetic hypotension, I think more reductions in cardiac output than anything else. And then there's certain disease states or animals that have a really profound effect from their epidural causing drops in systemic vascular resistance, that it may be that as the cause. I I gave this talk at MVMA, so I put this in there. We're fortunate that we have syringe pumps, but I was trying to get everybody to buy at least one syringe pump and one presser. We'll see if it worked. I do have what we have what, like 5 or 10 minutes. I do have if I can find it, I think I have another. Are there any questions? I have some case discussions if that would be helpful. Um, or you guys can just ask questions. Either one. I just had,
Some cases.
okay, let me try to find a version of this that has the case discussions. Um, uh, one, is it still sharing?
No.
Yeah, it appears like it froze. There's
Okay,
a
back? Okay,
yes.
great. Getting better at the technology. Okay, let me, I wish I could get that to go away. Okay. Is that super annoying with that up there? Okay. Anyway, okay, so this first one is a big boy coming in for a TPLO. Um, quick rundown, pretty healthy, older, pre-meted with hydro and ACE, was induced with propofol, had an epidural, and was being maintained on ISO. You're about 45 minutes into anesthesia, and this is what you're getting. So a mean of 52, heart rate of 130-ish. What would you guys think about?
Calling you. Yeah.
Okay. Elephant in the room. Sure. So can you decrease your inhalant? Step one, always a good thing. So check depth. Can you decrease inhalant? Does the heart rate seem appropriate for a dog this size? Yeah, I think I see high heart rate. I see low blood pressure. I think can I increase filling to decrease heart rate? So I would say check depth, fluid bolus. Oh, I guess okay. Oh gosh. Oh gosh. Okay. Yes. So, let's say you do those things, heart rate comes down to 104 and your mean is 59, which that's what will happen.
Yeah, yay.
So you give a bolus.
Is the ACE vasodilates and to get the heart rate to try to go down.
Yeah. Yeah, so I think at that point you could think about um, a little more fluid and a pressor. Since the heart rate remained pretty high, there was some response to the initial bolus. I would think about repeating that again and then starting a pressor probably simultaneously because now you're probably 10 to 20 minutes in of this very minimal response to fluids alone. Um, would there be a specific pressor you would choose? Yeah. I, I I would probably pick dopamine because I usually have it ready in the face of this is what I would call very standard anesthetic hypotension when I have done everything I can to not start a pressor to augment blood pressure and I get to this point where I'm like I really can't I don't want to turn down a 60 kg dog below 1% ISO, knowing that if they wake up, it's not fun.
Oh.
So most of these cases, I think about starting a pressor so I can actually keep my inhalant a little bit higher so the animal stays asleep. But I would probably grab dopamine because I have it ready. Dobutamine would be fine. Norepinephrine would also be fine, assuming with all of those that you have um, covered your volume side, which you guys nailed that. Okay, yeah, so this is pretty typical what we see every day. All right, Michael is a cute little cat with terrible heart disease that is having dental extractions for most teeth, normal blood work, and we're just going to assume Michael is hypotensive. Let's say he's bradycardic and hypotensive. And you have to be a little bit more sparing with your fluids in this cat.
This is the third one you'd use your special cat phenylephrine.
Potentially. I didn't make it seem like he's on death's doorstep, so I probably wouldn't in this cat. I was very basic in my descriptions. Let's say he can probably have a little bit of fluid and he's not on anything that is, he's not on a beta blocker to keep his heart rate low. So his heart disease is okay.
Would you like us?
Let's say his heart rate was 88.
Would you?
So most of these cats I find always need a dose of an anticholinergic, even though most of the HCM cats I do think a lower heart rate suits them better. By lower heart rate, I mean like 100 to 120 under anesthesia. And we frequently see them in the 80 to 100 range. And he's a young cat otherwise. So once we put him to sleep, I feel like this is kind of the poster child for the cat that will pretty quickly have a heart rate of 85, 86, 87. So beyond that, you give that usually works for, I don't know, 30 minutes and then your cat is hypotensive again. But let's say heart rate's now 120. Yeah, great. Perfect. And you guys, I don't know that there's really a good one. Again, I think when I made this and I made that driving home point that norepinephrine works a bit better in cats, I probably would start norepinephrine. But really, dopamine or dobutamine would have been fine too. Okay. Athena, we'll end with this one. We don't have to do the last one. Another big dog, another older big dog, having an amputation. So she has some decent pre-existing issues. DCM, she's on a good nest egg of drugs to begin with. And she's also coming in with probably some degree of renal dysfunction. So really, this is like my favorite kind of case, but probably most people's least favorite kind of case. So you really go into this thinking I need to maintain perfusion to the kidneys so I don't worsen her kidney function. But this is also going to be a case that's going to be harder to maintain blood pressure because she has such significant heart disease. So to start, just as since we do have a couple of doctors in here, this would be one that I would continue all heart medications up to the morning of anesthesia, aside from her ACE inhibitor. That is one that I want withheld without fail for 12 to 24 hours before anesthesia. A lot of literature on the human side and a few papers on the veterinary side now that in the face of these animals coming in on an ACE inhibitor without a withholding time period, or humans, really resistant hypotension under anesthesia. So that's kind of a good pre-op assessment, but antiarrhythmics, pro-contractility drugs, trying to think of other drugs, diuretics, all of those can be continued. Okay, so let's assume she's hypotensive. You're very conservative with your fluids, although there might be some blood loss, so you'll attribute for that. So you'll give a little bit of fluids, but what would you pick as your pressor of choice, knowing this dog's cardiovascular history?
You said Dobutamine.
Yes, good. God,
Oh,
you guys were listening. Thank you. Yeah, so dobutamine, this is the place and the poster child dog that dobutamine, because you really, whatever contractile strength you can try to muster up in this floppy, enlarged chamber heart, dobutamine would be your drug of choice. And then this just becomes a septic dog, but I think hopefully everybody feels comfortable with which drug should be chosen in the face of sepsis as your first line for hypotension.
Morebi.
Yes, great.
Well, that's all the criticals want to use anyways. So
Yes.
that's the right answer.
Yeah. So that's it. Any questions? Just feel a little bit better about receptors and drugs.
Could you, just for the people that didn't get to see your first couple slides, could you just roll through your first couple slides for the Zoomers at home?
Yeah.
And thank you so much for getting up early today.
Yeah, thanks everybody.
And coming to talk to us.
Am I still sharing?
No. Put your slide
No,
up. If I
not right now.
Okay.
Right now, no.
Yeah, I'm happy to email this out. That is it. These are not
Yeah,
sharing.
there was one picture one you had
Um,
that had what all the third, fourth one down.
Okay,
I
Zoom,
think that's what people miss.
share,
For the first 4 slides.
PowerPoint, share.
That's, yeah, we were talking about that.
Uh,
Well, if you're here or if you're signed on through Zoom, you will automatically get the CE credit for today.
There's that race credit,
No rest credit.
or internal credit for OBRS, yes.
It is race approved, this talk. Does it have to be through OBRS though?
If it was race approved for MDMA or whatever, they only have it for themselves.
Sorry.
That's okay.
Still counts for us here.
Great.
We still need 8. So.